Good evening, everyone. Here Imran Abbas. So we are live again. So with another well-known bariatric surgeon, and who is Hasan Husein Jalamneh from Jordan. He's my friend. He's a great surgeon. And definite, my viewers, you know better than me his beautiful videos, especially for sleeve gastrectomy. And definite, we will have many questions. And also, many of you already you have asked some question, and I will ask from Professor Jalamneh. Sir, because as you know, we have started this series of safe sleeve gastrectomy since July 2021 with Patrick Noel, and this series will continue till December. And in December, we will have some obsession. We will have repeated question, as you know, and that at the end, so we will try our best to convey this message. Sleep is good surgery, not bad surgery. But if you follow proper, so that guidelines. So due to this, I request all of these legends who are expert of sleeve gastrectomy, and they learn us how we do safe sleeve gastrectomy. Sir, over to you, sir, please.
Excuse me, Imran.
Yeah, please, sir.
Yeah. What was the question, Imran? First of all, thank you for having me in this series, but I didn't hear the question.
Sir, just your brief introduction.
Yeah. Well, I would like to welcome everybody who's seeing us now in this brief interview. I have started my bariatric career 10 years ago after working for 5 years as a general surgeon. And my passion with bariatric surgery started in Saudi Arabia when I worked as associate consultant in a tertiary center where so many bariatric procedures were conducted by many bariatric surgeons. So it was like a long, intensive experience for 5 years. And then when I went back to Jordan, my home country, I started my private practice. And since that time, since 2010, I'm working mainly bariatric procedures. We had 5 or 6 years of very high volume. And then after the COVID time, we started to have a noticeable regression in the volume of bariatric surgery. I don't see myself as a bariatric surgeon only. I'm a general surgeon doing bariatric procedures, plus many others laparoscopic procedures. And I think this is very important to highlight on that bariatric procedure is dealing with one of the most common diseases. It's the second killer on the planet. And we need to have an extensive experience and a good number of trained surgeons who can do safe bariatric procedures in order to come up with a good surgical resolution for this problem. And sometimes I've been discussing this. Do we need to be very restrictive in requiring some measures from the general surgeons in order to let them do bariatric procedure? I think we need to be in some way requiring some measurements, but I still think that bariatric procedures should always be under the umbrella of general surgery specialty.
Sir, excellent and a great message, definite. So you have mentioned, so now more than 1 decade, you are performing bariatric surgery. And also I am talking with someone who has experienced more than 1 decade. Sir, what percentage of your bariatric surgeries belongs to sleeve gastrectomy?
Yeah, I used in general do like 90% of my practice doing a bariatric procedure. More than 80% of this bariatric volume was coming from sleeve gastrectomy surgery. And there are some reasons why a sleeve gastrectomy procedure is very common in the practice of many surgeons in this part of the world. Probably we can talk later about the proper indication of sleeve gastrectomy surgery. But nowadays, the volume of bariatric procedures has went down remarkably. So I'm not doing more than 30% of my current volume as bariatric procedures, and the rest of my volume now is coming again from the general surgery procedures.
Sir, excellent. So, sir, we are interested because definitely you know better than me. Any surgeon progressively, so there are some evolution of his technique for better results. So, someone who is doing about 80% of sleeve gastrectomy and now more than 1 decade, he is doing bariatric surgery. Definitely, he has some changes. So this observation of results, side effects, complications and everything. We are interested to know that evolution point. So which changes you did in your practice for better results and also for decrease to chance of complications?
Yeah, that's a great question, Amran. You know, I still have some videos of my earliest procedure that I have done 10 years ago. I have the video of my third case. And, you know, every time I look to that video, I feel very ashamed of myself because there is a huge gap between what I used to do in terms of practice and the efficiency of me as a surgeon and the maneuvers that I used to do and what I'm doing right now. Bariatric procedure is just another procedure which requires a steady learning curve. And probably the learning curve in bariatric procedure is can be built up more quick than some other complicated procedures. But this is a very evolving field. I mean, we used to think that some specifications of a certain bariatric procedure is the best specification, but now we have changed our mind. I think we are still changing our mind. For example, when I started doing sleeve gastrectomy, I used to think that the more restrictive the procedure, the more benefit to the patient. I used to use 36 and 38 French bougie. I used to go very crazy, thinking that a good bariatric surgeon should leave a minimal but still patent sleeve tube. But very quickly I realized that's not working with all patients. We started to see what is called a paradoxical weight regain. The patient is not able to eat because there is a strong restrictive element. So they resort to eat the comfort food, and then they end up with not being able to eat healthy food and regaining weight. The second thing I think, which is associated with very tight sleeve gastrectomy, is the incidence of reflux, especially in the medium term. And you know, this is a very hot topic. And actually, this would be the Achilles tendon or heel for the sleeve gastrectomy. If we can find a remedy for this problem for sleeve gastrectomy, I think this procedure will last forever. But the problem is that after having this procedure on table for 20 years now, we started to see what real problem comes from a very tight sleeve. So first of all, the size of bougie has changed. Now I'm more inclined to use 40 and 42 French bougie. The second thing, I started to realize that a retained antrum could be also a contributing factor to the weight regain on the long term of results of sleeve gastrectomy. So nowadays, I'm doing an antral resection sleeve gastrectomy. And the reason for this, that I have noticed many patients who came with weight regain, and when I went in for a bypass procedure, I found that their sleeve gastrectomy tube was okay, but the antrum and the pylorus areas were very large. So I was more convinced that this part of the stomach, although it has very thick muscular layers, still can dilate and become a source of weight regain, exactly like fundus. So retained fundus or retained antrum are both, in my opinion, contributing factors to the sleeve gastrectomy. The third and last thing is something related to the complications, acute complications of sleeve gastrectomy, which is yes, Samran?
Yeah, I can hear you. Hasan, can you hear me?
Then I used to think that sleeve gastrectomy can happen for me now.
Yeah.
Imran?
Yeah, I can hear you, sir. Can you hear me? Hasan, can you hear me?
Yeah, I can hear you now.
Yeah, excellent.
Yes,
Sir, highlighted the very important points. So my question regarding, so definitely, good after sleeve gastrectomy, and as you have highlighted, after 20 years of sleeve, still we are facing this issue.
Yeah. I was, hello?
Yeah, I can hear you, sir.
Yes, Imran.
Sir, please continue.
We used to think that sleeve gastrectomy is the worst thing that can happen for a novice bariatric surgeon. But with experience, Imran?
Yeah. Please, sir.
With experience, I think that the improving learning curve and the improving material that we are using in sleeve gastrectomy makes now the leak is not as much as common as it used to be in the past. We started with leak rate of probably 3%, and it went down. I think now the acceptable range or the acceptable leak rate should be less than 1 in 1,000 cases. But I think we still, as bariatric surgeons, have problem with post-sleeve gastrectomy bleeding. And I believe this specific complication is the source of considerable morbidity after sleeve gastrectomy surgery. So to sum up, I think that I'm becoming less aggressive in fashioning a sleeve gastrectomy tube. I believe that antral resection now is as much as important as a fundal resection, and bleeding is much more common than leak, and this is something that needs to be concentrated up during the procedure, rather than being very obsessive of the consequences or side effect of sleeve gastrectomy.
Sir, excellent. So this you have highlighted so excellent points. So my question regarding your protocol for pre-op endoscopy and H. pylori eradication.
Yeah, regarding the H. pylori eradication, I don't do that routinely unless patient is very symptomatic. It means he has symptoms like vomiting or epigastric pain, and we have already ruled out other causes of epigastric pain like gallbladder stones or any other problem. But for an isolated result of H. pylori, I don't give triple therapy before the surgery. And if I'm going to start this, I would start it after maybe 2 weeks after the surgery is being done. Sleeve gastrectomy, you can go anytime, and I mean, there is no excluded part of the stomach, so that would not be a problem to survey the residual stomach. Now, the important thing is, do we need to do upper endoscopy in each in every case before they go for sleeve gastrectomy? My personal opinion, yes. I don't think that our patients are very talkative about their symptoms. They think that simple things like heartburn, which is occurring very infrequently, like 1 or 2 times every month, they don't report that. And the other thing is that I have seen so many cases where significant findings, which changed my opinion or my timing of the surgery, in very asymptomatic patients where I did the upper endoscopy for some other reason. For example, I do routine upper endoscopy for all patients who are older than 50 years old. So I used to find every now and then that some of these patients have very severe type of ulcers in the antrum area or in the duodenal area, which might cause problems after the surgery, especially that I'm giving routine anticoagulant therapy for an extended time of after the surgery. But the reality, we cannot do upper endoscopy for all patients for so many reasons. If the patient is covered by insurance, we always have problems with insurance to convince them that this is a vital part or vital investigation that needs to be done before the procedure. And the other thing, and I don't know why, we have sort of reluctance of our patients to go for upper endoscopy unless they are very symptomatic. The second problem is that I think we need to tell our endoscopist, if we are not doing our own endoscopist, that we need to look for certain things that we are concerned about when we are doing a bariatric procedure. For endoscopists who's doing a daily routine endoscopy, they usually go and report what they need to know about as internists. But we as surgeons, we need to know more information about the hiatus, the location of the GE junction. We need to know about the distance between the Z line and the diaphragmatic impressions. We need to let them know that they need to take their time looking to the hiatus, because this will have a certain impact on the choice of surgery. And even after doing that, we still have some patients who are reported to have like normal hiatus. And when you go inside, you find that there is an obvious anterior indentation of the phrenoesophageal membrane, or that there is a significant posterior hernia that uncovers itself when you do a generous mobilization of stomach, which I think is a very vital step in doing sleeve gastrectomy.
Sir, excellent. Really, you have highlighted practical points. Sir, can you share any presentation? Are you ready to?
No, actually, I didn't prepare a presentation, Dr. Imran, but
no issue. No issue, sir.
Yeah, I have like 2 videos. Let me see. Maybe Imran, we can have some more questions, and then until I find the videos.
Definite, sir. Sir, one thing that is the most important, in my opinion, and also this will be a good message for our youngsters, especially from a person who has more than 1 decade experience of sleep. In your opinion, what is absolute contraindication of sleeve gastrectomy?
Yeah, Barrett's esophagus and the grade D of reflux esophagitis, as simple as that. This is an absolute contraindication for sleeve gastrectomy procedure. And if we are talking about a relative or a highly not recommended type of patient to go through sleeve gastrectomy procedure, I think any degree of reflux esophagitis more than grade A or sometimes grade B should be counseled for bypass procedure. But there are so many conditions where we cannot offer bypass procedures to our patients. For example, in our country, more than 60 to 70% of our population are smokers. I'm talking about men and women. And for me, what is even more contraindicated to go for is to do a bypass procedure for a smoker, or
Yeah.
even for someone who has recently quit smoking. You know, the rate of smoking relapse after any bariatric procedure is very high. And I think that doing sleeve gastrectomy procedure for someone who has a grade B reflux esophagitis and who is a smoker, and you know that he's a smoker, he wants quit smoking, is much more appropriate option than giving him a bypass procedure and then he comes back to you with either bleeding or perforation or the least recurrent upper abdominal pains. So actually, I would still do sleeve gastrectomy for someone with mild, probably to moderate degree of reflux esophagitis, but I wouldn't do that for someone who has Barrett esophagus or suspicion of Barrett esophagus or grade C reflux esophagitis.
Sir, in your experience now about 10 years, have you faced any case of Barrett esophagus?
That's a good question, Amran. You know, I don't do my upper endoscopies. I have two endoscopists. One of them has been trained in the States for a long time, and the other one, they are both my friends, has been trained in UK. And they both concur on the fact that the incidence of Barrett esophagus in this part of the world is quite different from what they used to have in their places where they were trained. We can have a long discussion about the theoretical reasons for that, but believe me that probably 1 out of 2 or 3 thousands of cases can be diagnosed with Barrett's esophagus in our part of where I'm practicing bariatric procedures. So this is very, very uncommon finding. And it's not just not only coming from one endoscopist, it's coming from many endoscopists. I think that probably eating habits, lifestyle might have some impact on the incidence of Barrett's esophagus. So it's not very common disease. The other thing is that I think it's not being reported very frequently in our country or in some places because they don't look for it actually actively. Many patients are being endoscoped for no practical or scientific reasons, so they over see this. But again, as you said, for me this is not a very significant cause, not because it's not significant, but because it's not very common.
Yeah, I understand, sir, because Barrett, first of all, Barrett is very rare. And also we have a short segment and also long segment. So our main concern is only long segment. In Asia Pacific countries especially, so routinely we face, if we have in rare cases also, that is short segment. And there is no chance of malignancy in short segment. So routinely in, so okay, sir, this was again, so this is a contraindication. If someone, my question regarding this, because you are doing sleeve gastrectomy in a case till with esophagitis grade A, have you faced any worseness of GERD after sleeve gastrectomy in such a cases?
Yes, I would be honest and say in some patients, maybe in the long past, I had some cases where the reflux worsened. And the reason for that, I think, is a personal reason because I was not very keen to explore the hiatus. The problem of exploring the hiatus with someone who has a mild degree of reflux esophagitis is that you need to explore the hiatus in a way that you don't violate the hiatus and then you become committed to do a full exploration. So what I'm teaching my residents and my fellows that there is something called hiatus exploration and peri-hiatus exploration. And by peri-hiatus exploration, I mean that you need to explore the whole length of the left crust until you can see the decussation very clearly. And sometimes you you need to be able to go to the other side. And by having this view, you will be only very sure that there is no missed small or moderate sized posterior hernia that might be the cause of worsening reflux after the procedure. The other thing is that sometimes I look to the hiatus and I don't find a very obvious hernia, either anterior or posterior, but I can very clearly see that the segment of the esophagus, which is inside the abdominal cavity, is very short. You can spot immediately that the GE junction is abutting the left crust. This case for me is also an indication for a full hiatus exploration. So we need to close any potential missed posterior, especially posterior hiatus hernia. And we need also to make sure that we already have a sufficient length of esophagus into the abdominal cavity. And the third thing that I started to use 4 or 5 years ago is to do an artificial suspensory new mechanism to keep the esophagus into the abdominal cavity. And I started by doing simple gastropexy. And then I tried what is called ligamentum teres technique, or what I call it a falciform wrap. And I had some good clinical outcome, although I don't have like a very objective data to present for so many reasons, but I can tell you, at least in the short and medium term, that there are so many patients who used to have significant symptoms and significant endoscopic finding, and now they are symptoms free. They're not taking PPI, and I have been following some of them now for 3 years. And this is very interesting for me because I think this will increase the number of cases that are being denied sleep gastrectomy procedure because of reflux and all, I mean, the fear of future problems related to esophageal adenocarcinoma.
Hasan, excellent. Hasan, definite. We will discuss more about this hiatal exploration and also that falciform wrap. And I have received many questions regarding this, and I must ask. So, sir, first of all, so we want to know, is now routinely you explore hiatus?
No, it's by exploring. If you mean that I open the phrenoesophageal membrane, I don't do that unless I am intending to do a full exploration. This is very important, Amra. When you mobilize the fundus and you remove all the fat bed, you can spot the true location of the gastroesophageal junction, and you can see the angle there very clearly. If you go and violate the phrenoesophageal membrane, that transparent thick membrane connecting the esophagus to the edge of the left crust, where I start my dissection usually, if that area is violated, I think I'm committed for full exploration, even if I end up by having a small hiatus hernia that is probably so you need to look around the hiatus and see clearly that there is no posterior defect, no anterior defects, and the length of the esophagus is decent without having to breach the phrenoesophageal membrane. But on the other hand, surgeon has to have very low threshold for exploring the hiatus. And I think hiatus exploration should be a second nature for any bariatric surgeon. It's just a very vital technical step, exactly like the need to know how to deal with staplers and gastrointestinal anastomosis. So there is no point of being reluctant to explore the hiatus, especially if there is suspicion about hidden or occult hernia.
Sir, regarding this, if you compare, so just if we compare, because definite, so this exploration, if we compare now 8 years ago, 7 years ago, definite at that time, you will, I have no idea. So when you have started exploration of hiatus and are you think so there is, when you completely explore that area in selected cases, you feel so results are better?
Yes. Yeah. Yeah. The important thing is that I sometimes feel that some patients, they have an early postoperative reflux, and I think this happens because there was an obvious hernia. If it was, which if it was repaired, the outcome would be definitely different. The problem with reflux happening after sleeve gastrectomy surgery is not the early reflux that happens immediately after the surgery. I think this is related to bad technique since the beginning. The bad reflux, or the reflux that I'm concerned about, is the reflux happening after months and years after the sleeve gastrectomy surgery. Because even if you repair that area, or even if the hiatus was intact since the beginning, by removing all the suspensory mechanism around the stomach and making the stomach a very slippery structure, it constantly is being suctioned up by the negative pressure into the mediastinum. So I'm sure that in so many patients, if we can have the tool to have a look before and after, you would be very sure that the hiatus was normal, that it didn't need any exploration. And after a few months or years, patients started to have symptoms, and you go and you find that there is a significant hiatus hernia, and you start thinking how that was missed. I think that some of them, they were just not there. They were created by our dissection, extensive dissection, and not addressing the hiatus in the proper way. And that's why I'm telling you that you need to be very cautious. You need to look for the hiatus hernia, but you have to make sure that you don't disrupt the mechanism, or the protective mechanism in that area. Since if you have done that, then you need to do full exploration and close that area again, and do sort of gastropexy or falciform in a trial to keep having the sleeve gastrectomy tube into the abdominal cavity.
Sir, excellent. Hassan, according to your opinion, what is indication of falciform rare?
Yeah, I do that every time when patient has hiatus hernia or any grade of esophagitis that I know about before the surgery. So this is the typical case. Patient has symptoms. I send him for endoscopy. The report comes back with like 2 to 3 centimeter wide hiatus hernia and 2 centimeter long hiatus hernia with the grade A or B reflux esophagitis. So I go in with intention to do the falciform wrap procedure. The principle behind this procedure is quite different from the usual wrap or fundus wrap that we use as anti-reflux procedure. The fundus wrap works by keeping the esophagus into the abdominal cavity, but the falciform wrap does not itself keep the esophagus. It's just only a bed of fat that's covered by peritoneal surfaces. What I think keeps the esophagus into the abdominal cavity is the adhesions that we need to create between the posterior surface of the esophagus and the serosal surfaces of the falciform wrap. So this is the exact mechanism that I believe it works with. It's not like a fundus wrap. You don't need even to wrap it like 360 degrees. You just need to bring a serosal surface, make sure that it comes in contact with the esophagus, and fix that with a few stitches, and then let the body do the job itself. The second thing that I believe this technique is working by is it acts like an autologous reinforcement layer on the hiatus repair. Hiatus repair is not 100% successful. There is always a percentage of failure. So I believe that reinforcing that area with falciform might decrease the rate of hiatus repair failure in the future. Combining both of these factors probably are the reasons why this technique could be helpful.
Sir, excellent. Sir, the surgical treatment of G reflux, G reflux in a non-obese. So a patient with BMI 22, BMI 21, 23. So in this range, so routinely we do fundoplication. Have you any experience of falciform wrap in such a case?
No, no. Actually, I don't offer this for any patients who's clearly a candidate for a classical or routine anti-reflux procedure, whether it's Nissen or Tobe, whatever it is. I still think that this is an experimentational procedure that should not be offered to a patient who has another option which is known that it works. For those patients with BMI less than 30, we know that anti-reflux procedures work very well. So I don't think it's even ethical to try to convince them with this procedure unless this comes under a very strict research protocol. We offer this for patients where they don't have fundus, where they lack fundus because it was resected in the sleeve gastrectomy. We have nothing to wrap it around that area. So I think in that area we can do that. We can try to decrease the incidence of post-operative reflux by whatever means we can do, and at the same time without subjecting the patient to undue or unnecessary harm. Because I heard about some other procedures which are being done as anti-reflux procedure combined with sleeve gastrectomy, but I still have some reluctance to offer them to my patients until we have full picture about the very exact rate of acute complications and the efficiency of this procedure in preventing reflux on the medium term and long term as well.
Excellent. Hasan, definitely we are scientists and also we love our patients. And when patients are happy, so definitely we go ahead. So regarding this, why I am asking regarding this falciform wrap, because I received many questions regarding this. How many cases till this time have you did? And also, are you happy and your patients are happy with this technique?
Yes, they are very happy. And you know the deal, Imran, this patient is going to have a sleeve gastrectomy. He doesn't have any other choice. Most of them are smokers, or they don't want to be or to have bypass. And by saying they don't want to have bypass, I don't mean that I didn't counsel them for bypass. Imran, you are practicing this and you see this every day, that there are so many patients, they just don't want to have bypass. They are being educated about the bypass, being told about all the potential and advantages of bypass over the sleeve gastrectomy, and they still don't want to have bypass. You know why? Because when I present both procedures to the patients, I present them with their exact advantage and disadvantages. So bypass is still a morbid procedure, in my opinion. It's been there on shelf for 50 years. And surgeons around the world, they are trying to find an alternative for bypass every 10 years. And they come up with a new procedure because bypass has its own problems. So when this patient is going to have a sleeve gastrectomy, I do my best to make sure that the incidence of postoperative or medium-term reflux is less than expected. So either I do a falciform wrap, which is something that does not impose any increased risk on the patient, because it's just only an patient's own tissues being utilized in the same area. We are not subjecting patients for any not necessary risk for having like leak or bleeding or using other organs that shouldn't be touched or approached. So I think this is very safe procedure. It's a very safe extra 10 to 15 minutes that you add to the time of the procedure. And I don't think that if it failed, it would have any significant impact on the wellness of the patient.
Sir, excellent. Hassan, are you prefer to do sleeve gastrectomy in large size hiatal hernia?
No, yeah, I think this is probably another relative contraindication. The problem with large size hiatus hernia is not about being able to reduce the hernia or close the defect. You will be able every time to close the defect, and you will be surprised that so many large hiatus hernia will be closed by a few stitches. But I think the dynamics and the physics that governs the area in this part of the body will change very soon after patient is out of the operating room. And I again believe that the mediastinum is a beast. It has the power to suck up, as you know, half of the abdominal viscera into the mediastinum. So
Yeah.
it's not contraindicated, because you will have difficulty in repairing it. You will be able to repair it, and if you have or if you are if you don't have problems of using mesh at that part, probably you will place mesh in that area. But I think that recurrence rate of hiatus hernia when the hernia is large is not acceptable. So I don't think that sleeve should be our first option here.
Sir, thank you. Have you faced any intractable GERD after the sleeve and you have converted to Roux-en-Y or other surgeries?
Oh yes, very frequently. And I'm talking about my patients. Put aside those other patients that I treat them who didn't have their sleeve gastrectomy with me. I'm talking about my specific patients. Some of them, they have intractable reflux. And I think that when patient has intractable reflux, it's not just only about failing to treat or to approach the hiatus area. Many of them, I found that there was a problem on the outlet of the stomach. Either there was a twist or the incidural area is very tight for any reason. Some of them, I was sure that their incidural area was left very wide, and then they had this narrowing at that area, which can happen even with being very cautious. So it's multifactorial. Those patients who have intractable reflux, usually they have problem with their hiatus, which was not addressed or addressed and failed. And the second thing, they have problems with the area of incisura. And most of them, they would also report that they have problems with eating. It's not just only about reflux. Many of them will tell you that they cannot eat solid food like they used to or they are expected to have after many years of the sleeve gastrectomy. And I routinely, although I believe that mini gastric bypass is a good option for patients who have reflux, but I don't think that patient who had a sleeve gastrectomy and acid reflux should be subjected to the possibility that he would have acid and bile reflux if he is fixed a mini gastric bypass or one anastomosis gastric bypass.
Sir, excellent. Hassan, one of nightmare, in my opinion, after sleeve gastrectomy is leak. So maybe you have faced personally or your colleagues. So yes, in sleeve gastrectomy, yes, progressively with after this MDT and preparation and staplers and technology, yes, we are facing less. But overall, yes. So during this period, so what do you change to decrease the chance of leak after sleeve gastrectomy? For our youngsters, that key points, please highlight what they must do, then there will be less chance of leak after sleeve gastrectomy.
Yeah, they have to approach the incisional area in the proper way. I mean, any problem that you do in that area will be reflected later on the gastroesophageal junction area. So it's not just only about having a clean, straight, stable line. The incisional area has always to be very patent. And even if you think that resecting the antrum will cause a non-acceptable angulation or tightening of the incisional area, we should abandon that. I don't say that resecting the antrum is a must that you need to do in all patients. You have always to look at the incisional area and then plan your first firing. So this is the starting point. The second thing, you need to have your stable line straight and located all the distance up at 3 o'clock position. If you have a spiraling of a stapler line or if the posterior line is located anteriorly, this means that the patient will be subjected to increased risk of twist. And this twist can come up because the stomach is a mobile organ, and the stapler line, if it gets stuck or to the lower or internal surface of the liver, that can be a fixed point causing a fixed spiraling or twist. So in order to avoid this complication, the stapler line should not face posteriorly or anteriorly. It has to come exactly all the way up at the 3 o'clock position. The third thing, reaching the gastroesophageal junction, you have it's your duty to make sure that you have left shoulder there. If you go very flush or flush to the esophageal junction, you will be entitled to have a leak. And with my experience, leak in that area, if there is no sufficient gastric tissues left back, is sort of nasty leak. So sometimes I tell my fellows that they need to remove the bad fat in order to be able to clearly visualize the gastroesophageal junction and then to be able to estimate the amount or the distance that they need to go away from the esophagus. So basically, there are three things: addressing the incisional area in the proper way, trying to have a regular stable line all the way up to the GE junction, and not going very crazy, cutting the stomach in a close relationship to the GE junction.
Hassan, excellent, really. And this you are talking exact your experience. Amazing. Sir, you also have highlighted about bleeding after sleep. So what they must do so for so less bleeding after sleep gastrectomy?
Imran, we should not rely or trust a stapler line. No stapler line can be trusted. Whatever the brand of staplers you are using, even if it is the latest one, even if it's being presented as a smart machine that's putting the stapler line, it can never be trusted. So either you oversaw the whole stapler line down to the last 1 centimeter, or you might use some sort of reinforcement or clips. In my own practice, I usually implicate the proximal 1/3 or 1/4 of the stapler line because I utilize that part of the sleeve gastrectomy in my Gastropexy step. And the rest of the stapler line, I put titanium clip. And I asked my anesthetist to increase the blood pressure and to reach a mean arterial blood pressure more than 100, and then observe the stable line. And in any case that I am doubtful about the stable line hemostasis, I usually deflate the abdomen, wait for 5 minutes, and then come back and have a look again with the stable line. So my message here, you should never trust a stable line. Sometimes you might be required to place a titanium clip every 1 centimeter in a prophylactic manner. And the problem with that is what some of our colleagues present, that if surgeon needs to come back and do sort of stabling, some of this titanium clip can come into the jaw and cause misfire. And I'll tell you that I revised some of my cases where I put like tens of titanium clip there. It's always an easy task to go and get these titanium clip away of your way, but you have to look for them. I mean, they will not be very attaching to the stable line. When you come back after 5 or 6 years, you find that these titanium clip are just only attached to the peritoneum overlying the stomach. So you will be able to, if you are planning to place your stabler, you will be able to look and find all of these titanium clips and remove of them. And I think the risk of having misfire does not justify not using them, because they are very efficient way of securing hemostasis in the stable line. In the same time, they are very cheap. You don't need to use the hemostatic reinforcement material, which I never used, because these materials are designed for rich people and rich surgeons. But I think, again, that titanium clip is very useful way to address or to secure hemostasis of stable line.
Hasan, what is your experience or opinion of Momentopexy?
I don't do that, and I don't think it does the job that it's supposed to do. I think Momentopexy is used as sort of anchoring mechanism to try to keep the stomach tube into the abdominal cavity. But as you know, Momentum is very mobile organ, so you cannot rely on that. If you would use, if you would utilize the same mechanism, I think fixing the stable line with the transverse mesocolon is more logical to me, because the transverse mesocolon and sometimes the peripancreatic fascia are fixed types of tissues. But the Momentum, I would say it's very beautiful at the end to look to the procedure, but I don't think that they have a role in preventing postoperative reflux.
Sir, excellent, sir. So what percentage of your patients experience significant weight regain after receiving gastrectomy during this 1 decade?
Yeah, Amran, I'm not sure that any surgeon can tell the truth about this, but I'm very pretty sure that no less than 30% of our patients, sometimes 40%, they will regain weight. This is a very heterogeneous group of patients. I mean, there are so many reasons for weight regain. It's not just only about the technique or about the power of the procedure. It is also about the eating habits, about so many factors that cannot be controlled with every patient. I mean, you will have weight regain in some patients that they have lost significant amount of weight. They have sustained their idle body weight for a long time, and then they regained all the weight they lost. And when you investigate them, when you do for them CT volumetry or upper endoscopy, you find that your procedure or the procedure that was done is a perfect one. So why are they regaining weight again? So it's not just only about the technique or about the what is the procedure is supposed to do. It's about the eating habits, and I think this is the most important thing. Trying to educate patient, tell them that this is a chronic disease that he needs to deal with for the rest of his life, and at the same time to have continuous follow-up with these patients. Patients who are not following up with their doctors, I think they are more prone to have a weight regain. But again, I think it's not going to be less than 30%. And I say that without being able to follow up like even 20% of my patients, but I still have a certain significant rate of weight regain of my own patients that I have fixed them sleeve gastrectomy.
Hasan, really, it was excellent, in my opinion, interview, and lot of points that you have highlighted, and definitely it will be very, very fruitful for our youngsters. So we are interested. So any message, sir, to hear your message for our youngsters who are just now going to start sleeve gastrectomy?
Yeah, my main message is that don't start with a sleeve gastrectomy as a step-up procedure. I mean, don't offer this procedure to your patient because you are not experienced with other procedures. Don't try to convince yourself as surgeon that this is the best procedure that can be offered for all patients. And at the same time, I tell you that there is a significant part of patients who are a good candidate for sleeve gastrectomy procedure. And if you look to the obesity and deal with it as a chronic disease, then it's very logical to treat this chronic disease with a staged approach. If you start with the sleeve gastrectomy procedure, please do a lot of attention to hiatus area. It's not just a part where you need to have a brief look on it. You need to address it in a very good manner. You have to look for the shape of the hiatus, look for defects, and you have to evaluate the length of esophagus. And in any time you feel that the hiatus is not normal, then don't hesitate to explore and fix it. The third thing is that part of the success after sleeve gastrectomy surgery comes from the preoperative education. You have to have a very intensive course and a very strong message to your patient that this procedure and all other bariatric procedure, they will not work by themselves unless you work with them. And I would say that all patients have to be educated about sweet eating. It's just, if I'm going to summarize the problem with all obese patients with obesity, with bariatric procedure, it all comes some way from strict sweet eating. This is the most constant factor in my belief that is associated with weight regain and medium and long-term failure of bariatric procedures.
Sir, excellent, really. And Hasan, it was great message, and you have shared your practical things, and definitely it will be fruitful for our youngsters. Sir, so much thanks, and also my viewers, so much thanks till this time. And we need your support. With your support, we can continue this series of safe sleeve gastrectomy. If you have any question, you can ask in comments, and personally you can ask, and Professor will answer these questions. We will continue this series of sleeve gastrectomy, and next week, Tuesday, 10 p.m. Dubai time, we will be with another expert of sleeve gastrectomy. Sir, again, so much thanks for your time, and hope very soon after this COVID era, so practically we will meet each other. So much thanks, sir. Thank you.
Thank you, Imran, for having me. Thank you.
Thanks a lot. Thanks a lot. Thank you, sir.
Bye-bye.
Bye, sir.